And I would like to invite our distinguished panel of experts for this session. All of these doctors devote most or all of their practice to myeloma. There's Dr. Reese, again, the director of the myeloma program at Princess Margaret. Dr. Chen, a longtime member of the myeloma program at Princess Margaret. Dr. Lozada, who has been in London for only a few years now, but in that time, the patients in the London area and around southwestern Ontario are tremendously appreciative of what she does. I think she's so focused she didn't even hear that.
About you.
Dr. Hira Meehan is now a staff hematologist at the Juravinci Cancer Center in Hamilton. And I believe, Dr. Meehan, you're going to devote your entire practice to myeloma.
Yeah.
So that is tremendous. All of these four doctors see a large number of myeloma patients in their clinics. In addition, each one of them contributes significantly to myeloma research. This session is going to be moderated by Martine Elias. Oh, there she is, the Executive Director of Myeloma Canada. So again, please give Martine and our distinguished panel a most warm welcome.
Lot of questions. I'm going to try to do justice to many of them, but I'm just going through them myself. First thing, I want to, for your information, we're not going to be asking or answering questions that are specific to your condition. So this is, obviously has to be discussed with your clinician. These are, we'd like people to ask general questions, and so if you have a specific issue or question you want to ask me, we ask you to do this after the presentation. So I've got a lot of questions here, and I'm going to try to sort of collect them and to put them into sort of themes here. So this is an interesting question because sometimes many patients come to our website and ask these kinds of questions. So first I'm going to start, does long-term drug therapy, 8 to 10 years, affect brain cognitivity function? So I'm going to throw it to our panel. Maybe Donna, you want to start?
I think that is a really, really, really important question, and one that's been neglected in clinical trials. I don't know the answer, but it's something we do hear from patients as they don't feel as crisp, or their mental faculties don't feel quite the same. There is a body of literature, and there are investigators that are looking at this. Some of this started with breast cancer and adjuvant therapy, and women noticing that their cognition was different. I think there is something to it. What it is, I don't know. But I think the research world is starting to take that into consideration. I think people do return to a good level of functioning, but is it completely the same? I don't know. I think it's obviously a very important question as longevity is becoming the norm with myeloma, and we don't. We need to move beyond just trying to keep people alive for a few months and really look at this aspect of quality of life. I don't know if anyone else has more details on this, but it's been an under-studied aspect, but the time is ripe.
Yeah, one thing I find interesting is that we all call it chemo brain, and it's been known to be caused by actual chemotherapies. But in myeloma, many times we're not using chemotherapy. We're using immunomodulatory drugs, we're using the proteasome inhibitors or antibodies, and we still see that. So there's got to be something that's not just, so the bad guy, the villain, is not simply a true chemotherapy drug, but definitely those other drugs do influence as well. And I find it quite odd, but interesting.
And if I could just add that a lot of patients have concurrent problems like anemia. They are in pain. They're taking other pain medications. It's really hard to weed out the decreased cognition from drugs versus, attributing it to all these other health issues. So that's probably one of the big barriers to studies being done specifically to look at this chemo brain effect.
Yeah, and just to add to Christine Chan's point, I think age also, how it relates to some of these cognitive changes, and dexamethasone is another big one, again, when we're adding that variable in as well, and how that's playing to some of the cognitive changes, I think is interesting as well.
I mean, hopefully we'll get tools to do this. I think one interesting aspect, it has to do with fatigue, and particularly after a stem cell transplant for those first few weeks or months. Why, when the blood counts are fine and the medication list is low, why do people have such profound fatigue? And there is some very limited research to say it has to do with cytokines, little chemical mediators that probably mediate fatigue with arthritic disorders like rheumatoid and such like that. But really it's an understudied area. Hopefully will be explored more.
Thank you. This is a really hot topic question because there's a lot of issues about measles outbreak in the news. So the question is, should myeloma patients be re-immunized for measles, since we are hearing so many issues about this in the media? So do you want to answer, Christine? Dr. Chen? Or
Sorry,
I
Hiram was distracting me, so I
I
didn't actually hear.
distracted her. I'm sorry.
Sorry, could you just repeat that again? I apologize.
Should patients be re-immunized for
re-immunized,
measles
okay.
because of the outbreak that we're
Oh,
seeing
that's a
right
good
now in the
question.
media?
That's a good question. This is a relatively new thing that we're actually seeing this huge influx of, or outbreak of measles because of the lack of vaccinations from when people were younger. And the question for us now is really, what should we be doing? We don't routinely revaccinate with live vaccines. Like the MMR are not vaccines that we usually look at because of the risk in terms of getting infections from live vaccines. This is why we were talking about Shingrix before. That's a non-live vaccine. The diphtheria, pertussis, tetanus, those are fine to administer. We actually routinely, post-transplant, give patients a list of vaccinations that we recommend they either be tested for and then revaccinate. But that's a very good question that we've been actually pondering right now with our infectious disease team, whether or not we should be actively looking and asking about it. That's something I think many of us don't even ask, like, were you properly immunized when you were children?
Okay, thank you. I have a question for Dr. Reese here. Triple therapy for induction and maintenance, or just induction? So I think the question is, should triple therapy be used for induction?
Well, I think it's standard before stem cell transplant. And I think for non-transplant, right now we have funding for a bortezomib triplet, VMP or Cyborg-D, or just RD. Now, there is access increasing through compassionate programs in some provinces, not Ontario, to use both bortezomib and Revlimid, RVD, in older patients who are not going to have a transplant. And there is some promising data that that can be given if the doses are adjusted and reduced and given less frequently, that can be well tolerated and may not, and not unexpectedly, give a long RVD in the trials we have available has a longer first progression-free survival than just RD. And I think when we're looking at going down the roadway, if patients have RVD and then stop the V and continue the R, like maintenance in the elderly, then there should be access to a bortezomib triplet like with DARA later on. So the funding, I think that's under review for funding. But right now, compassionate access is available in many provinces, as I understand it, and it's a reasonable option.
Okay, thank you. I'm going to go through many of these questions because there's a lot, and they're all very good questions. I don't want you to think that I'm sort of discarding your questions because they're not good. It's just I have to try to sort of summarize them and put them in different categories. So if you don't have, you're not satisfied, or if you want to know more, you can either come and talk to us. We'll provide you with some of the information, talk to some of the clinicians that are going to be here throughout the conference to address your question. But this one is seeking second opinions. What is the process and any advice? I don't know who wants to tackle that one. Maybe you want
So
to
I guess, I'm from Juravinski, and we're right next to Princess Margaret, so everyone doesn't want a second opinion from Princess Margaret, and I would say we're very open to it, right? It's if you think that there's additional questions you want to ask us, and if you think that you would benefit from a second opinion, we're more than happy to kind of refer you on to whatever, whether it's within our department or to another department. I think because myeloma is a disease where really you're building a relationship with a physician over a long time. Both parties have to be comfortable really saying everything. So open communication from that perspective is it's really important. So again, figuring out what part of it that you want the second opinion about. Is it, in first line treatment and second line? Are there additional questions that I perhaps hadn't answered initially that is leading you to want the second opinion? But I think a lot of us are really open, and our colleagues are incredibly open as well. So from Hamilton, when we need kind of advice, if it's over the phone or whether it's a formal second opinion, we have lots of avenues to refer you on.
If I could just add to that, even within our centers, we're always asking each other opinions. Every week at Princess Margaret, we meet and we discuss challenging cases. So whether you know it or not, you are getting a second opinion when we tell you what we think is the best thing for you.
And sorry, Dr.
I think there's also a lot of emailing among physicians and a very good camaraderie. I think we all feel that we're helping our patients by being able to bounce ideas off because everyone's a little bit different. So even if you can't physically go to another center, there's a lot of phone call and emails that happens all across the country, which there's a lot of sharing of that. And I think that's a very good thing for our patients.
This is a question about the dose of Revlimid in the maintenance setting. We know that the dose has to be modified, and it's not approved by Health Canada, but it's been used, it's been funded because the evidence is strong enough to use Revlimid in maintenance. What is the dose and why is it modified, and what are the potential side effects? Donna, maybe?
This is a subject near and dear to my heart because my bias is we overtreat people with too high a doses many, many times. That's my bias. It's not proven, but Vishal Kukredi and one of the residents did, I think, a very useful analysis of maintenance in our center, and because it's no good in many ways to have someone have a transplant and then make them sick with maintenance. I mean, that just doesn't make any sense. And our patterns have evolved to reduce the dose. And Revlimid has two properties. It's an immune modulator and it kills myeloma cells. And there's a lot of discussion on how do you leverage one aspect of that with doses and different situations. But in this analysis, it was over 100 individuals, and we figured out if the target dose in the studies was 10 milligrams a day, we were starting out at an average of 8 milligrams a day. Almost everyone had dose reductions. And at the end of 3 years, which was the observation period, the average dose our patients were getting was 6 milligrams a day. And our results in terms of progression-free survival I showed you were exactly like the reported literature. So I think that raises the question that maybe those low, well, it was reassuring that those low doses weren't just treating ourselves. And we had some quality of life assessments. Those annoying DART forms you're asked to fill out were actually used to look at basic quality of life, which was maintained at a good level. And I think it's reassuring that using low doses, if that's what's needed for tolerance, is a reasonable thing to do, presumably because we're leveraging the immune effect. Now, that's not been shown in a proper phase 3 trial where half of patients get 5 milligrams a day of Revlimid maintenance and the other half get 10. But I think in the real world setting, low doses seem to be effective, and I think that's so important for a long-term drug. But I would ask other people's opinion, particularly Chris. Because we practice in the same center, and you know, we have different perspectives, and this was not studied in the phase 3 setting.
Right. So we do argue a bit about this within our group as to whether we should start at the standard dose that was established, and we know the efficacy of, which was 10 milligrams, and actually the studies allowed you to escalate to 15 milligrams, which we never get to, given continuously, every day, no break. And I know that Donna and others in the study that Vishal did has started to wear down some of us to actually start off a little lower, or do 3 weeks on, 1 week off, like we do the schedule we use for treatment, rather than a continuous daily dosing. I really do agree that the 3 week on, 1 week off schedule that gives people just a bit of a break now and then, and it also helps people's blood counts recover if they're starting to run into trouble with their low neutrophils or platelets. That said, if my patient post-transplant is pretty healthy, has pretty good blood counts, and I usually just start at the 10 milligrams and I play it by ear. If they don't tolerate it, I'll drop it. And the first thing I do in dropping is I drop that extra week. Also remember that 80% of lenalidomide is excreted by the kidneys, and it doesn't always, it's not always very apparent if you're just looking at your serum creatinine that your kidneys are not functioning well. And we know at least half of myeloma patients have some kidney dysfunction. And so it's not uncommon then to see that the dosing you're using might build up a bit if your kidneys are not working properly, or even just fluctuating. And most of all of the maintenance trials really didn't allow anybody with significant kidney dysfunction on the study. So we don't really know what a right maintenance dose is in somebody who has kidney failure.
Do you have a nephrologist on your staff?
We have we have nephrology that we engage with, and they're very interested because we have a whole onco-nephrology team. The group is led by Chris Chan, which is ironic because I get a lot of dialysis calls and stuff on his behalf, and he gets oncology questions. But their group has started this large collaboration with people who are interested in nephrology and oncology, and myeloma is a big disease area that really merges those two areas. So yes, we have specialists.
Yeah, we're starting to get onconephrology fellows rotating through our clinics a year at a time, and you may see them because they're seeing patients. And they really add a lot because we can ask them the questions because I think kidney function's a big black box. And they can help advise us. And another thing, since renal kidney dysfunction is so common, even though we're not trigger happy, sometimes it really helps to get a kidney biopsy and see, is the kidney problem from myeloma, or is it something else that needs to be treated or taken out of the equation? And having that relationship to really sort out kidney function, because a goal is always prevent dialysis, has been a real step in the right direction. And there's some really good fellows from all over the world coming. So
Number of questions around secondary cancer due to Revlimid. Maybe Dr. Luzada, can you expand on that? What are the secondary cancer that could be expected?
So, a risk of secondary cancer is a bit higher when patients are exposed not only to lenalidomide, but also patients that are exposed to melphalan. And those are two drugs that we do see in patients that undergo transplant. And if they use melphalan in the non-transplant setting, eventually they will be exposed to lenalidomide as well. So the risk is there, the risk is true, but even though it's on lenalidomide, this risk is considered to be higher than with other drugs. The risk is still pretty low, around 3%. So the problem with myeloma, I think, is based on the fact that most patients are older, and the older age is where the most incidence of cancers will come. So can you have colon cancer when you are 30 years of age? Yes, you can, but it's way more commonly seen when you're past 55, 60 years of age. So it sort of goes along. Because lenalidomide works and influences on the immune system, what it may do is it may shut down your immune system to recognizing some cancer cells, and then those cells will be able to freely grow, and then you will eventually develop a malignancy that's different from your multiple myeloma. I think it's very important that whenever we are considering lenalidomide for our patients that we bring that up, but screening and follow-up are usually just based to what the standards are. So if you are more than 65 years of age, you need to start doing screening for colon cancer. Females have to keep their pap smear on board. If they are at the age of doing mammograms, then they should be doing their mammograms. But we don't need to go overboard and start CT scanning everybody and requesting tumor markers for everybody just because they started on lenalidomide.
I think, this is a bit reminiscent of what we saw in Hodgkin's disease. The goal was to keep people alive, and then with radiation and chemo, and then secondary cancers popped up as people started living longer, and I think there's some echoes of that going on. One slight good aspect is if one looks at the incidence of fatal secondary cancers, it's very low. Mm-hmm. That's not to say it's acceptable to have more cancers, but the danger mostly is the myeloma. But I think it's really important that we find ways to minimize that. I am intrigued, and I don't think it's at all proven, but if you look at some of the studies that have given Revlimid maintenance 3 out of 4 weeks, the follow-up isn't as long as the original ones that gave, but maybe the incidence is a little bit lower if you give a week off. All immunosuppressive drugs can carry a risk of other cancers. So it would be nice to find that sweet spot, which we will potentially can use our database to do, but I think we are trying to capture this important sequelae of treatment, mm-hmm. and potentially devastating.
Okay. Thank you. You mentioned several times the national database, and there will be a talk tomorrow on the national database, so you'll learn a lot more about it. It's a very exciting tool, and Dr. Reese mentioned thank you for being part of it. If you are not, then you can certainly talk to her later, or to Dr. Venner, who will be here tomorrow. But it's very useful for us when we do our advocacy to governments to show them why and how drugs are being used and the benefits of them. So just want to mention that. Number of questions around triple therapy, and sort of how do you manage, given that they're now available, but governments are saying you can only use one? How do you decide how the patient, what patient will receive? So. Tough one. There's a few.
We're all passing on that one.
Yeah.
So, okay.
Thanks, Dr. Lozada, for
Who wants
taking
to
that
take
one.
So, well, CCO came up with you're only allowed for triple therapy after first line ones, but they have a specific definition of triple therapy. So they consider triple therapy, with all due respect, maybe they don't know how to count, but they consider triple therapy if you're giving 2 of 3 drug preparations. So if you're receiving an IMiD with a proteasome inhibitor or a monoclonal antibody or any variation of those 3, if you're having 2 of them plus dexamethasone, then that's a triplet. But if you're having a triplet that doesn't include two of them and only one, for instance, carfilzomib, cyclophosphamide, dexamethasone, that's a triplet, but CCO doesn't consider it a triplet. So that is the difference. So it doesn't mean we will never be able to. But if you're considering that you want to do, for instance, a second line DRD, that's daratumumab, monoclonal antibody, Revlimid, that's an IMiD. So that's a triplet. So if after that you want to give, for instance, carfilzomib, pomalidomide, and dex, you can't, because that's a triplet, according to CCO's vision. So I don't know if, that helps.
I think it has to do with the cost of drugs. The new drugs, bortezomib, which has come off patent and the cost is somewhat lower now, but Revlimid, POM, carfilzomib, Dara, all just think of them as $10,000 a month drugs. So, we don't know what the provinces actually pay, and there are differences, and of course Dara is given front-loaded, but so someone is funded for one regimen where 2 expensive drugs are given at the same time. But when you use cyclophosphamide, that's sort of off their radar screen. It's cheap. It is not $10,000 a month. So that can be given. Dex is inexpensive. But for those drugs that are $10,000 a month, you can use them 2 of them at a time once. And the other consideration is the trials were done not comparing triplet with triplet, but triplet with doublet. So, we'll go up in arms and make a lot of noise, but there is no data to say that you should go from Dara RD to carfilzomib RD to pomalidomide, Dara Dex. There's no data for that. So I don't think there ever will be, but that's the rationale behind it, is the cost. And again, I never want funders to think that we're happy with what they've done, but actually compared to some countries right now, till the next generation comes out of using these drugs first line, right now we're in a pretty good place for our patients, I think. It's been a long wait, but I'd much rather be here than many other countries. So, but I don't want that. Pardon?
What happens if the patient offers to pay?
Oh, you're very lucky. If it's Health Canada approved, sometimes you can. I only have had 1 or 2 patients pay cash for drugs. It has to be given in a private infusion center. If it's parenteral, it can't be given in a cancer center because of the Health Act. You can't have someone that's buying a drug that's sitting next to someone who can't access it. So, for instance, daratumumab as a single agent in very advanced disease, patients can get that through private insurance or rarely pay for it, but they have to go to a private infusion center, not in the cancer center.
Questions? If you want to ask a question, you can get a microphone, please, because it's hard for us to hear.
What if the patient paid the first time they got the triplet? therapy. And now you have a system that's saying they can't have it because they only get it once. So they didn't access public funding the first time they got it.
That's a tough question. I'd have to talk to you about that afterwards, because there could be some questions about your private insurance versus public insurance.
I think the other thing that's changed is now we're finding the pharmacist, to get these triplets, particularly with DARA, have to list all the treatments someone had off the grid and on the grid, and they can request our clinic notes. So in the past, you could just put what patients had, but now it's the pharmacist doing it, and they have to show clinic notes. So that we fudged a lot for a long time. Maybe Dr. Chen didn't fudge.
I never fudge.
Yeah.
You don't say things like that in a room full of people. Close the doors.
But I don't think we can fudge. No, we can't fudge anymore, because hopefully it's not necessary anymore in the usual situation, but we really can't. The submission for these drugs to be funded is much more extensive now. And it's not done by us. It's from the medical record, which is a legal document that's available to the people paying for our health care. So I don't think the off the grid or this or that, like we used to do it to try to procure drugs for our patients, is relevant anymore.
It's getting harder and harder,
Yeah.
and they're on your side, you can tell.
If I could just make a comment about that, though, it is a cost-saving measure, obviously, in a big province like Ontario, where, if everyone gets unlimited access to these expensive drugs given in any way, then it would break the bank. But so you have to keep that in mind, but also the fact that what Donna said is we don't have a lot of data that supports that if you had it the first time off the grid, that you would necessarily benefit equally well as an alternate drug combo than repeating that triplet. So, you may be frustrated by that, and we are as well, but we just don't know the data. And in some respects, unlike in the US, where you can sort of use any combination you want as many times as you want, and then you end up really not getting a real answer in the end. There is some advantage to us having to follow some kind of algorithm, and then we follow the studies and the data to know which populations of patients really do well with retreatment of the same drug they had before, or maybe switching to something else. So it's, I'm just trying to temper this, that we don't really want to throw everything in whatever combination that you want.
And also, you can't forget the older regimens. I mean, I can think of all sorts of situations, an individual who had carfilzomib, pomalidomide, and dex on a trial with high-risk cytogenetics, and had a year remission, relapsed, had a year with Cybor-D after that. There's the whole issue of when the disease progresses, what's that clone sensitive to? Is it sensitive to something someone's had before, something we can use again? I think when we look at it, we basically have 4 lines of good modern treatment that are funded now. There are some gaps for those people that may have missed daratumumab because they're beyond eligibility for a combination with Velcade and Revlimid, and that's a very high priority group for us for MCRN, and however we can get access programs for that group of people. And I don't want to be naive, but I think there will be progress for that. It's a very high priority. But other people will have good first-line treatment, have a DARA regimen second-line treatment, KD third-line, POM fourth-line, and then all these trials. For these extremely expensive drugs, and I hear that myeloma is the most expensive cancer on every provincial.
That's what we're told. When I meet
I
with
don't know.
governments, that's what I'm told.
But we also have the clinical trials with the quadruplets coming. And the quadruplets are all made with those wonderful but expensive drugs. So eventually that will come up in the pipeline. I don't know. If relapse setting, we already have DARA VMP approved by Health Canada. it's a quadruplet up front. So it gets complicated.
Now, I'm going to ask Dr. Mayan this question. It has to do with dose reduction, either of daratumumab or Kyprolis, carfilzomib. I mean, before you sort of take the patient off because maybe they're having side effects, would you consider dose reduction, and how would that work?
So I think, again, with the Revlimid, a lot of times we've been empirically dose reducing, especially kind of in older patients that are more frail. I think the first thing in terms of dose reduction is that we have to have a much better sensitive way of figuring out what the comorbidities are and what the functional status truly is that will lead to some of these dose reductions. So right now, in terms of daratumumab and carfilzomib, there's no good data to say that empiric dose reductions are often needed. I haven't been doing it, at least with daratumumab at all. But it is part of a kind of a larger question that we're really interested in. So hopefully over the next 2 years, we're doing an expert North American consensus, really looking at empiric dose reductions based on functional status. So hopefully we'll have some more data around that.
If I could comment on carfilzomib, because we know that carfilzomib can lead to hypertension, kidney dysfunction, fluid overload, and much more likely in patients who already have cardiac dysfunction. So I do routinely start very low with carfilzomib and build up. You usually start at a 20 milligram per meter squared dose, and then you go up to your next dose that you're going to land on, but I often step it up slowly. And just see how people tolerate as they go along. Because if you develop a toxicity, like your kidney function goes off, then you're stuck having to stop it and wait till that toxicity resolves, which may end up being a lot longer of a delay than if you're slowly building it up. So I have kind of adopted that with carfilzomib, especially, as I said, in those who are older or have cardiac disease to begin with. Daratumumab, I tend not to do anything different. It's usually split dose for the first dose, and the toxicities I don't think are really dose dependent. You could give a smaller dose, you'll still have infusion reactions, so we don't usually change the dose there just off the bat without seeing some toxicity emerge first.
Okay. A few questions here on biphosphonates. What's their benefits and what's the risks?
I think they're a good adjunct to preserving bone and are useful particularly in people who have compression fractures. I do think we tend to overtreat, and because when we think in terms of continuing it without thinking about it, because that's how the very initial studies were done. It was given for 21 months compared to placebo in advanced disease, and it's before the modern era of drugs. It worked to reduce skeletal events, then everyone got it once a month for years. But bone's dynamic, and we have to remodel. And we build and then we sculpt depending on how our weight changes. And we know that bisphosphonates build bone, but don't allow sculpting. And that's what led to the osteonecrosis of the jaw. The jaw has to continually remodel because of the intense pressure with chewing, and our teeth shift and this and that. And if you build, and the bone can't remodel, there's a risk that the inside bone will just die. Then that may not cause problems, but when you pull a tooth, it never heals. So I think there's a sweet spot with bisphosphonates. You want to use them in people with bone damage, but when the disease is in remission and people are off steroids and not breaking down bone, I think it's quite important that there's a holiday, because there is no, if the bone is dead, holding bisphosphonates for 2 months and pulling a tooth, dead bone is dead bone. And there are other bones that can crack if they're not allowed to remodel. So I think in an ideal world, there are tests to monitor if bone breakdown's being done. And in the studies that have been done, if people are in remission, they're not always breaking down bone. So those tests are not funded, But I think we don't want to give too much of a good thing. They are very important, and we don't see people with collapsed spines like we used to. But when we think of biologically what they actually do, we don't want to continue it forever. And so I think, again, it's almost like secondary cancers. We dealt with the problem that we had that was immediate with people with terribly bent spines. That got better, but now we need to be wise on how we use these drugs.
Thank you. There's a few questions on medical marijuana and immunotherapy, and we do have some sessions later on in the conference that will address those, so I'm going to skip that. Just got a few minutes and a number of really good questions. This one actually is quite interesting because we know myeloma patients, there's not that many in Canada. And do you do research in collaboration with international clinical trial groups and collaborate, let's say, with the US or Europe?
All the time.
Yes.
All the time.
All the time. We do, if no one else wants to talk. Never one to be quiet. We participate in all those trials. Many industry trials are international, and Canada generally does very, very well in accrual to these trials. Then we have trials that are with other non-pharma groups in the US through CCTG or through networks like MMRC. We have our own trials across Canada. I mean, we'll go where the drugs are available. So.
Thank you. There's a question about what is the appropriate level of vitamin D that a myeloma patient should take?
That I'll pass.
Who wants to take that?
You guys.
We're setting a trend here. Okay, then.
I think I have seen people overdose, come in with calcium levels sky high that we're taking 10,000 units a day, and that's not good. But I think 1,000 to 2,000
I think it's reasonable.
a day. I don't think more than that is going to do anything. I think calcium can be obtained through diet. And if someone doesn't have a good calcium diet, gentle supplementation is good. But I think 1,000 to 2,000 units a day.
Yeah. I think there's a lot of fuss about vitamin D and about cannabis. Those are the two wonder medications of the moment. Everybody's going to be, happy and healthy forever because of those two. And I don't think it's really that. I think common sense is the way to go. And the standard for anybody that needs vitamin D3 replacement, which is the best one that's already available to start working, as Donna is saying, is 800 units for kids and up to 2,000 for adults. So I don't see a reason to go anywhere beyond that.
And no IV vitamin C, please.
Yes.
That acidify. If you talk to the Mayo Clinic, that acidifies the urine, that promotes light chain excretion in the urine, that can damage your kidneys. It will not help.
Very sage advice. So on that, I'm going to close the morning session. I know this has been very dense, and we thank you very much for your attention. And I'm going to pass it over to David, who's got just a few words, and then we'll break for lunch.